you. Thank you. Thanks to Prakash for the very kind invitation. I have a 10-minute presentation followed by some recorded cases, so I'm just going to run that through as one long presentation. Oh, I'm sorry, let me go backward. So importantly, I will be discussing non-FDA approved devices and indications of devices. I think there's little doubt that obesity is very important. It's quite prevalent. Here you look at the incidence of obesity, actually of being overweight, that is BMI greater than 25, as a function of different countries over the course of about 3 decades. And you see, if we look at the US, for example, the significant increase in number of individuals who are obese. And actually, this was a New England Journal of Medicine publication that just came out yesterday, where the Global Burden of Disease collaborators, they analyzed 68 million different records from 195 countries over the course of 2.5 decades. And there are a couple of interesting points. First, 2/3 of the world's population is overweight or obese. If you look at just obesity, that is BMI greater than 30, it's 710 million people worldwide. Importantly, 5% of all children are obese, and this seems to be increasing, particularly in Western countries. 12% of adults are obese. And interestingly, the United States has the greatest number of obese adults, which is approximately 80 million people, and it's approximately 35% of the population. This is the incidence of obesity as a function of each country in men, and this is in women. And you see that in general, women tend to be more obese than men. Interestingly, India and China, although the relative prevalence of obesity is relatively low as a percentage of the population, because of the large number of individuals, China actually has the second highest number of obese individuals. It has important health effects that all of us are well aware of because of the effects on inflammation, the increased lipids, the increase in the sympathetic nervous system, as well as the renin-angiotensin-aldosterone system and mechanical stress. There are a number of different cardiovascular and non-cardiovascular conditions that are increased. And it also has an important effect on mortality. You look, when you go from the overweight to the obese, that is a BMI greater than 30, you see an almost exponential increase in the risk of death. And interestingly, the converse is also true. This is from the Diabetes Prevention Program, and what they showed was a relatively small decrease in the weight had a significant impact on the development of diabetes. For every kilogram of weight loss, there was an approximately 16% reduction in risk of developing type 2 diabetes. Now, what about treatment? Well, we certainly can start off with diet and lifestyle, and this, in general, gives a relatively modest amount of effective weight loss. It's really when you get to some of the surgical procedures, such as a lap band, and ultimately the gastric bypass, that you start getting substantial decreases in weight. And of course, the other problem is getting weight loss and then maintaining weight loss. And then we have these patients who are right here, which is a relatively large percent of patients who clearly are not going to be able to get to the ideal weight by diet and lifestyle alone, but who also probably are not appropriate for a surgical bypass. If you look at the surgical bypass procedures, you can look at the gastric banding, which gives the relatively modest amount of weight loss, is used in only 7% of patients. And then the two that are the most commonly used are sleeve gastrectomy and the Roux-en-Y gastric bypass, which can give you about 30% effective weight loss. And this is used in the majority of patients. What's interesting with all of these procedures is that all these procedures seem to affect the gastric fundus, which is the main source of gralen production. What's gralen? Well, gralen is the hunger-stimulating hormone produced in the PD-1 cells lining the fundus of the stomach, as well as in the epsilon cells of the pancreas. It's the most potent appetite stimulant. In fact, it's the only known hormone in the human body that actually increases hunger. So the levels slowly increase over the course of the day before eating, and then fall after eating, and not surprisingly, they increase substantially when dieting. So the question is, if gralen reduction is one of the mechanisms by which weight reduction is achieved surgically, can we target gralen for weight control in a catheter approach? So this is based on what's known that 90% of the gralen is produced in the fundus of the stomach. And the left gastric artery is the principal arterial supply to the gastric fundus. We know that arterial embolization can be done. They certainly are used for bleeding arterial vessels. And there's the possibility that embolization may decrease gralen production, reduce weight loss. I'm not going to spend time on this because we're going to be showing a bunch of videos. But let's look at how this is developed. Well, Arapelli and colleagues demonstrated that you can have suppression of gralen in porcine models. And then when we come to the clinical experience, one of the first and interesting publications was to show that there appeared to be weight loss. This is non-randomized studies. There appeared to be weight loss after gastric embolization for bleeding in patients. And then there was a first-in-man study dedicated to obese individuals, and I'll come back to this. There are several US physician-sponsored IDEs that are going on in the United States right now, as well as one randomized control trial that we're involved with that I'll talk about. So if we look at the preclinical studies, these are several of them. These are the number of animals, and you can see a number of different agents were used. Let's first look at what the effect was. In general, it appeared to be favorable in terms of weight. There was either decreased weight gain, that is, the animals failed to gain weight appropriately, or there was actually increased weight loss. Now, initially, there were corrosive agents that were used, and what was interesting is there was a significant amount of ulcers, gastritic, or esophageal strictures. Eventually, when we went to particles, particularly larger particles, the investigators found that these ulcers were no longer occurring. What are the reasons for this? Well, the submucosal artery is approximately 200 to 300 microns in diameter, and that's the location where the PD-1 cells reside that actually secrete gralen. If you injected smaller microspheres or a corrosive agent, you'd expect it to enter the mucosal arteries, cause greater amount of damage in this location and ulceration. On the other hand, if the vessels are mainly the submucosal vessels that are occluded, well, there's enough collateralization here that the concept is that perhaps you can cause ischemia without ulceration. Here's an example of some of the animals where the corrosive agents were used and those ulcerations that were seen in significant percent. The other concerns, and again, we just think about the anatomy. Here's the celiac trunk, and remember the celiac typically, not always, but typically trifurcates to the left gastric, the splenic artery, and the hepatic. Now, the left gastric is where one wants to embolize, but if one is not careful, you could embolize into other location and cause non-target embolization to the other vessels, or importantly, even branches of the left gastric that can go, for example, to the diaphragm or the esophagus. I want to show you two examples here of antegrade and retrograde reflux. So this is an example of retrograde reflux using a standard microinfusion catheter. And you see the problem is, as you inject contrast here, you can see contrast coming backwards, going into other non-target territories. Now that's retrograde reflux, relatively simple to understand. But there's also the problem of antegrade reflux because of collateralization. So if one is injecting, if you inject with too much pressure, you can actually end up going into these other territories just because of the increased pressure. So you can embolize into non-target collaterals. So this is the first in-human study. It was done in only 5 patients. These are obese patients. You can see the 4 of the patients were male. You can see the age. They're relatively young. The weight was pretty high with the BMI, average BMI of 42. And you can see the baseline gralen levels. From a safety perspective, there were no peri-procedure complications. All the patients had endoscopy performed. There was no ulcerations on any of these patients, though the patients did experience acute epigastric pain in the day following the procedure. And they all reported a decrease in appetite. Here's the data on these 5 patients. The dotted lines represent the individual patients, and the solid line represents the average. And you can see over the course of 12 months, the gralen levels did decrease over time. They may have come up a little bit at 6 to 12 months, but again, less than what it appears to be less than what's at baseline. Of course, remember, small numbers of patients. And here's the weight reduction over the course of 24 months. So it's expressed as a percent of baseline. You can see that at 12 months, there was about an 18% weight reduction. Again, small numbers of patients. Now, this is a very busy slide, and I apologize for that, but these are data from mainly different abstracts that have been published, including 2 publications from a number of different institutions. If we just look at the average, or the summary here, there have been a total of 58 patients that have been reported, with follow-up ranging from very short follow-up of 2 months out to 24 months, showing a mean effective total body weight loss of 9%, which is quite reasonable. there was a relatively high incidence of minor adverse events, and this is mainly nausea and vomiting that occurs particularly within the first 24 hours after the procedure. And there were no reported instances of major adverse events, such as ulceration, major bleeding, etc. So these are some of the early lessons from this experience, that bariatric embolization is technically feasible, and at least in the preclinical and the early clinical experience seems to be effective. There was evidence of gralen suppression and weight reduction. But I do want to remember that gastric artery embolization causes appetite suppression. It's not inherently a weight reduction approach. So the goal is that this has to be used in combination with some sort of behavioral modification and weight treatment program. The early experience suggests that embolic spheres and particles are ideal, and the size and location are critical to occluding at the submucosal level. And certainly, there's concern about non-target embolization. And this really raises the question whether the off-the-shelf devices can really be used for this approach. The clinical generalization is probably going to require the development of a dedicated microcatheter infusion system. And it's to this point that we've become involved with this particular technology made by a company, OBarr Solutions, where, let me just see. Oh, yeah, okay, sorry. With the OBarr Solutions, where this particular company has come up with two different important devices. One is the microinfusion catheter with a balloon to prevent retrograde infusion, retrograde reflux. And the second is an injection manifold with pressure feedback to ensure no antegrade embolization, non-target embolization. So using this technology, we've started a placebo-controlled sham treatment, single-center randomized control trial, where 40 patients are being randomized in a one-to-one fashion to either gastric artery embolization or a sham procedure. The main inclusion criteria is a BMI greater than 35, and we're not looking at diabetic patients at this point. And it's being conducted between two centers in Prague. The primary endpoint is safety, of course. All patients undergo endoscopy at baseline and at 1 week. Of course, we're looking at weight loss. The primary endpoint is at 6 months. We're also looking at 12 months. We'll be looking at visceral fat as determined by ultrasound, as well as a 6-month CT angiogram. And there are a number of important secondary endpoints, particularly the effect on gralen, as well as hunger scores. So with that, I think I'm going to go ahead and stop. I actually have run a little bit over my 10 minutes to see if there are any questions, and otherwise we'll go on to the recorded cases. I actually can't see anything from here. The light is too bright. Okay. Go ahead. Okay. So I'm gonna go ahead to the cases. If we could go back to the slides. We can go back to the same slides. Okay. So I just have a few cases that I thought would be interesting to go through. And I apologize if the quality is not as good as we'd like it to be. So the first point is finding the celiac trunk. And for people like me who don't normally do this or didn't normally do this, this might be useful. So we're looking at T12, and you'll see once we start playing, you'll be able to see the ribs coming off of here. So this is T12, and this is approximately the location we start looking for the celiac trunk. So, okay, so here's a catheter. It's a little bit high up, too high up, bringing it down a little bit more. You can see one of the ribs here and one here. And finally, we seem to engage something. We inject, and you can see that was the splenic artery. And here's a better injection. So as you inject here, you can see several different things. One is the splenic artery, which is quite tortuous. And then here you have the hepatic, along with, and actually this is a wire. You could tell that we didn't tighten the screw very tight, so the wire actually was just following. This is a woolly wire. And then finally you just see the ghost of the left gastric artery right here. It typically is the smaller of the three vessels. You can just sort of see it faintly coming up here. And once it comes up, it's branching. So these are the vessels that are going toward the stomach. And then this, let me play this again. And then this branch right here is going somewhere else, going toward the hepatic, toward the diaphragm, etc. This is the same, this is again injection in the celiac, looking at the REO view. And you can see some vessels like this one going up to the phrenic, and you can also see other vessels like this one, which is the gastric, left gastric, right here. And then, this is looking at this in an LAO view. In this particular case, the LAO view, this is the left gastric right here, and I can't quite see the ostium, but it's somewhere right around here. And this is, again, an AP view, just looking a little bit closer. And again, this is the left gastric right here. So we cannulated the left gastric, and I'm going to show you some other cases where we struggle actually with cannulation. And this is actually the microinfusion catheter that we're advancing over a angioplasty wire into the left gastric. Then we inject contrast, and you can see when we inject contrast, you have the bifurcation here. There's the vessel here that goes toward the stomach, which is this is the branch that we'd actually want to embolize, as well as another vessel here, as we saw before, that's heading toward the liver. So here we cannulated this branch and advanced our microinfusion catheter over this. And here we're injecting. The balloon is, I believe, is inflated, so we're injecting. You can see as we inject, the actual stomach is somewhat outlined here, the mucosa of the stomach. So at this point, and I'm not going to actually show you the actual manifold and everything because I don't have pictures of it, but anyway, we inflate the balloon to prevent retrograde reflux, and then you can't really see this very well. We're actually injecting the microspheres, which is in a suspension of 50% contrast, and it's actually slowly being injected into this vascular bed. Now, I should say the manifold has a pressure feedback, so to make sure that the force of injection or the pressure of injection is not too high so as to prevent antegrade reflux into inappropriate vessels. So it's a good question. So the question was, what catheter are we using for our guide? And we changed quite a bit. I mean, there are a number of and I have to say that there is no ideal catheter that we've come up with. There actually are some deflectable sheets that we've played with that actually seem to work quite well in terms of engaging. The problem with those are relatively stiff. I'm sorry? We have used the Simmons one. We've used there's a, I'm going to forget the name of it, but there's the same sheets that we use for actually the renal artery, renal angiograms. I mean, it's the same sheets. The distance is about the same, as you know. But again, what's interesting is, I'm showing you the cannulation of the left gastric. Actually, I didn't even show you that cannulation in this case. As you'll see in some of the other cases, that's actually part of the most difficult part of the procedure. The left gastric is oftentimes a small vessel coming off of a big celiac trunk, and I don't know what the ideal sheath is. I think we're still learning what the ideal sheath is. Sometimes using a retrograde sheath, so a sheath that curls back, is sometimes useful. And then here, I'm sorry, let me go back one. So this is injection. So when we're injecting contrast after the microspheres, you can see this branch seems to be relatively occluded, but then there's still this branch that's still pacified. So we decided to move this catheter back proximally and inject again. Inject again if it plays. There we go. Okay. So we moved it back proximally and injected more microspheres. And there we're injecting again. And then this is the final contrast, and you can see there's a significant amount of contrast holdup with this injection. I didn't really talk about this, but I should note that these visceral vessels seem to spasm quite readily, as you're well aware. So we typically give nitro just after we enter the vessel. I don't know how effective that is, but we think it's somewhat effective. And then this is I'm sorry. Okay, so that was the first case. Now let me show you another case. This is the second patient, and here again we're injecting into the celiac trunk, and you can see relatively quick trifurcation. This is the splenic, this is the left gastric. It's actually a really nice left gastric, and this is the branch that we'd want to actually look at, and this is a non-target branch. And there was also, you can see the hepatic branch going off to the left. This is the same in RAO view, and here with an angioplasty wire trying to engage this vessel. And then here, this is just us trying to get into this. And actually, sometimes pulling the catheter back a little bit, or the guide catheter back, allows us to get into the vessel a little bit easier. And here we just entered the left gastric artery. Now this is zoomed in a little bit. So this is the left gastric, and we've actually advanced the sheath a little bit. This is the branch that's going off to the liver, and this is one of the branches that goes to the fundus. This is the main branch that goes to the fundus. So you can see again, it's relatively plump, and you can see the vessels that are going to actually the mucosa. So we've now cannulated a smaller superior branch, which is not where we want to be. So we would draw that, and then we put it into the more inferior branch. We have our microinfusion catheter that's advanced over this. And this is an occlusion angiogram, again in AP, looking at this particular vessel. No, we're not trying to take out the entire left gastric. In fact, that's a problem, because if you took out the left gastric at its most proximal point, you would get embolization. You would affect parts of the liver, and more importantly, you would affect the phrenic, and you'd affect the esophagus. And that would be a huge problem. That's right. So there are diaphragmatic branches that are here, absolutely, that we have to avoid.
What do you do to manage anticoagulation?
Yeah, managing anticoagulation. Yeah, good question. So I remember one of the first couple of cases that we did, we thought this would be a relatively quick procedure. We wouldn't need to give anticoagulation. And we realized pretty quickly that that was not correct. And now what we typically do is give 5,000 units of heparin at the beginning of the procedure, and we have all of our flushes with the heparin, spiked with heparin. And then after the procedure, and I didn't talk about that, after the procedure, we typically just have the patients either on an antiplatelet agent, or if for some reason they need to be on anticoagulant for a couple of weeks. Couple being 2.
What are the microspheres that you're using? Is that PVA or?
Yes, so these are PVA microspheres. They're between 300 to 500. I can't remember the company that makes Beadblock. Beadblock, yeah. Okay, and here we're just we injected the microspheres into this vessel. And this is just the final injection at the end. You can see a little bit of spasm right here. That's actually a trivial amount of spasm. There are other cases where we've had much more significant spasm. This is an interesting case. This is a case where, I'm sorry.
Onyx is too risky for onyx.
I'm sorry?
Onyx, would you consider onyx instead of microspheres?
We haven't played around with too many other, I don't know, it might be useful. Let me just go through this one quickly. This is an example of a case where it's really difficult to engage the celiac. You can see this is an REO view. You can see that it's, our sheath is just not reaching here. We eventually put there's an angioplasty wire inside of the hepatic branch, but we still were not able to engage with our guide catheter. So ultimately, we ended up putting 2 angioplasty wires next to each other. That helped. That gave enough support that we could advance this over this buddy system. And then I'm going to show this in a couple of different ways. Again, you'll see this is in an AP view, and you can see this is the splenic branch, the 2 angioplasty wires are in the hepatic, and this is the left gastric. Looks like I have a minute left, so I'm going to go through this rest of this really quickly. So what we ended up doing was leaving 1 wire here. We put a 2nd wire up in the left gastric. This is the wire in the left gastric. So this allowed us to engage and advance our microinfusion catheter into the branch, and then we ended up injecting. The last one I want to show you in the last couple of seconds, I have a minute and 20, more than enough time. Okay, this is an interesting case. Okay, this is the case, again, we're injecting here. We inject the celiac, and you see the splenic, you see the hepatic, but you don't see the left gastric. Now, the first thing we do when this happens is we try to move the sheath back, because if it's an early branching of the left gastric, you may miss it. But ultimately, there was no left gastric that was trifurcating. This happens sometimes, and in fact, what ended up happening was the left gastric, if I play this, it actually comes off of the hepatic branch. Let me go to the next one. And what you'll see, what we ended up doing is we advance into the hepatic branch, and then there's a late branch that goes all the way back up here. And so ultimately, we put an angioplasty wire up there. There's a microinfusion. We're injecting in, and you can see it's coming over here. We advance. We advance the angioplasty wire, then our microinfusion catheter engaged, and then finally injected. And I think that's,
That's not a bad way to go. That's the right gastric.
I'm sorry, I keep saying left gastric. It's the right.
Yeah, so you could take the right gastric all the way around the back.
That's right.
So that may be easier than the left
Well,
gastric.
this patient didn't have any left gastric that we saw.
Right, I
so
saw
this
that,
is,
yeah.
That's right. So it's a branch of the right gastric, absolutely. Okay, thank you very much.
I like it.